Hi, my name is Eric Notless, and I'm joined by Jihei Oh. We are PhD students at the University of Michigan, working with a large interdisciplinary team of clinicians, computer scientists, database administrators, and our advisor, Dr. Jenna Weems. We prospectively validated a patient risk stratification model and characterized the performance gap. The performance gap quantifies the difference between how we estimate a model will perform and how it actually performs in practice. ML models are routinely developed and validated with data collected retrospectively. For example, let's go back in time to before the pandemic, to 2019. I might use data from 2018 to develop a model, data from 2019 to validate the model, and have the goal of applying the model in 2020. Here, how the model performs in 2019 approximates how we expect the model will perform in the future. However, after integrating into clinical care, the model may perform worse in 2020 than it did in 2019. This gap in performance is often attributed to temporal shift or changes in care processes and patient populations as the data drift away from what was observed during development and validation. For example, a large shift in the use of personal protective equipment could affect model performance. However, differences in infrastructure, that is when or how the data are stored, extracted, and transformed, may also affect the performance gap. How does infrastructure differ? Well, models are typically built using data from large retrospective databases, like a research data warehouse. These databases extract from the EHR, transform data, and then store it for research purposes. However, when it comes time to apply the model prospectively, we can't rely on research databases since data may take days or weeks to go from EHR to the curated data warehouses. Instead, we rely on additional infrastructure like web services that serve data in near real time. Thus, both temporal and infrastructure shift can affect prospective performance. Validating on data extracted retrospectively from a research data warehouse from the most recent year seeks to mimic temporal shift, but does not account for infrastructure shift. In practice, we'd expect differences, but to what extent? I'd like to turn it over to Jihei, who will show you how we answered that question.
Hi, my name is Jihei. To answer this question empirically, we trained a model using data from 2013 to 2018. We retrospectively validated on data from 2019 and prospectively validated on data from 2020, measuring the performance gap. After the prospective validation period, to control for temporal changes, we repulled the data from 2020 using the retrospective pipeline and measure the gap due to the shift in infrastructure versus the shift in time. Applied to the task of predicting which patients are most likely to acquire an infection with Clostridioides difficile during their current hospital admission, our patient risk stratification model performed similarly in 2020 to how it did in 2019, with the exception of a couple of months at the onset of the pandemic. Overall, in 2019, the model had an AUROC of 0.778. Prospectively, this decreased slightly, resulting in a gap of 0.011. However, this gap was not due to differences in patient populations or clinical workflows. The temporal shift was negative, meaning the task got easier in 2020 relative to 2019. In contrast, infrastructure shift was positive and drove the majority of the performance gap. We identified infrastructure shift as a primary contributor to the performance gap. The EHR is inherently dynamic. When you access data affects what you access. Data can change after the fact. To the extent that we continue to rely on large curated retrospective databases for model development and validation, we will continue to observe differences. To learn more, scan the QR code to access the full paper and or stop by our poster. Thank you.